Welcome, everyone. Thank you for joining us in today's webinar, Return to Work Among Healthcare Workers Injured Due to Workplace Violence. My name is Yusra Benjeloun, Administrative Coordinator and Projects Manager with the Work Wellness Institute, and I'll be moderating today's webinar. We thank our academic team and our 9 founding partner organizations in the Harnessing Talent Projects Alliance for recruiting and retaining Canadians with disabilities and mental health challenges. If you would like to learn more, please visit our website at harnessingtalentalliance.ca. This webinar is made possible through the support of Employment and Social Development Canada, as well as donations and memberships to WWI. We thank our advisory committee and speakers who contribute to this webinar series. So while we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing, any comments you may have, and any questions related to the webinar. We will collect questions submitted throughout the webinar and follow it with a Q&A based on the questions submitted. Please note that the Work Wellness Institute is recognized by the Society for Human Resource Management, SHRM, to offer professional development credits. This program is valid for 1 PDC or Professional Development Credit for the SHRM CP or SHRM SCP. Our institute also offers accreditation recognized by VRA Canada. If you are a WWI or VRA Canada member, you receive free certificates of attendance. Otherwise, there's a $15 administration fee. We're very excited to welcome Dr. Esther Maas. Dr. Maas is working as an honorary research associate at the Partnership for Work, Health and Safety, which is a partnership between WorkSafeBC and UBC. She is supported by a CIHR fellowship and is working on a program of research on the evaluation of workers' compensation policies and programs, with a particular focus on identifying effective and cost-effective approaches in facilitating early and sustained return to work after a musculoskeletal injury. Esther, thank you so much for talking to us about the return to work of healthcare workers injured due to workplace violence. I will hand it over to you.
Perfect, thank you. Thank you so much for this very kind introduction and for the opportunity for me to present here. So I've been working for the past years for the Partnership for Work, Health and Safety on multiple projects, and one of them is the project I'm going to present to you today. So Return to Work Among Healthcare Workers Injured Due to Workplace Violence. It's a project I worked on with a student of mine, Kelvin Choi, and two of his supervisors, Professor Mieke Koelhoorn and Professor Chris McLeod. And I thought before we jump into the nits and gritties of the topic, I thought I'd give you a little bit more information about the Partnership for Work, Health and Safety. Because as already kindly introduced, it's a partnership between the Workers' Compensation Board and the University of British Columbia. And it's a really unique ongoing collaboration, and it's really unique in the terms of that most universities don't have this continuous collaboration with an industry partner or with the Workers' Compensation Board. And I think it's so unique to have this ongoing and always have the data that we can do so much research with. So most of the data that we work with and that we do research with comes from the Workers' Compensation Board of British Columbia and is provided through the Population Data BC. We work with a very diverse and multidisciplinary group of faculty, staff, and students. So, for example, like we are embedded in the School of Population and Public Health at the University of British Columbia, but there are many other faculties that we work with within the Faculty of Medicine mainly, but also in the Department of Forestry, or like many other groups of researchers and people in practice that we work with. For example, we also work with the Institute for Work and Health, the Institute for Safety, Compensation Recovery Research, Occupational Cancer Research Center, CareX. So all these collaborations already give you probably an idea of how diverse and the collaborations are that we have and how diverse the research is that we do. So I will focus today on return to work, but there are many, many other research opportunities and research projects that we have. So this is also like funded by many different funders, like what I was kindly introduced. I'm funded by the Canadian Institute for Health Research, but there are many other funders of more than 20 active projects we have now. So if you want more information about this, please take a look on our website. It's the www.pwhs.ubc.ca. So there's information about all our projects in case you're interested. And we also have a Twitter account. So yeah, if you want to know more about the research we're doing, please take a look on these websites. All right, but for now, I focus on one of the really important issues in healthcare, and this is inpatient violence. So inpatient violence has been a long-standing issue among healthcare staff in BC. So we look to investigate the effects of violence and specifically return to work outcomes after injuries due to violence compared to injuries due to any other cause in the healthcare and social services sector. And this is a quote that I took from one of the other research projects focusing on violence done at the Partnership for Work Health and Safety. And it really indicates why it's so important to study violence in the healthcare setting. So this is one of the nurses who says, "I think it's just the nature of our caring and the fact that we are in a caring profession that we tend to overlook and just absorb some of that anger and violence when we don't necessarily have to." And for me, this is striking. Never think it's something to just be absorbed. Like violence is never something that has to be overlooked and just to be absorbed some of the anger and violence when we don't necessarily have to. Like it's never accepted. So this was one of the quotes that I thought was very important in the projects that we do on violence in healthcare sector. So give you a little bit of background of how big or what is the burden of workplace violence. So the prevalence of workplace violence is often underreported and it's very difficult to estimate. So the numbers I state here are probably an underestimation, but just to give you an idea of the burden of workplace violence. So in British Columbia, the yearly rate of compensated violence-related work claims among healthcare workers is between 0.4 and 0.5 claims per 100 person years. So this is difficult to grasp how big this is, but understand that this rate is 3 to 10 times higher compared to any other industry. If you want to read more about this, please check the WorkSafeBC website. All right, so it's also a problem in other industries or in other jurisdictions. So for example, I took some numbers out of the US. So the burden of workplace violence, yeah, it's high in other jurisdictions. One of them is the US. So the number of workplace assaults and violence act in the USA averaged 24,000 annually between 2011 and 2013. So nearly 75% of this is occurring in the healthcare and social services sector. So that's why it's so important to focus on these sectors. So the focus of all our work on violence in the healthcare sector is to develop a systems framework that integrates multiple sources of evidence to identify specific indicators that track or predict the risk of violence or can be used in to evaluate prevention programs. So I think that's also very interesting for people who are listening now, who are maybe working in the field. I saw occupational therapists, but maybe also nurses who are watching. Like maybe you have experience with violence prevention programs, and I think it's really interesting throughout this presentation to see if you can relate to these numbers and if you can see how this can be used to evaluate violence prevention programs. So we published on this in occupational and environmental medicine. So I put the link here at the bottom. I'm not sure if you can see my mouse, but anyways, so I can send you the link if you're interested. So we published a paper on time to return to work following workplace violence among direct healthcare and social workers, and we published this here. So yeah, please contact me or the organizers from this webinar after to get more information, or if you want to hear everything, because of course we're limited in time, so I can't explain everything. But this is where all the information is. Okay, so going into a little more detail of what did we compare and how do we compare, or how do we evaluate the effect of violence on return to work. So here I have a little graph. So imagine that you're a nurse who faces a violent event, after which she has a certain type of injury and is off work for a period of time before she returns to work, right? And then to evaluate what is the effect of violence on this time until return to work, we compare this to another nurse who faces a non-violent event, but maybe has a different type of injury and is also off for a certain period of time before returning to work. So these are the two comparisons, two trajectories that we compare. And what I want to highlight is that violence may be associated with certain types of injuries that may also affect the worker's return to work process. So this may be due to the severity of the injury itself, but it may also take longer for more serious injuries because of trauma or the threat of violence happening again, so that workers do not return to work at all. So there's a lot going on in this trajectory. We can't only say that a violent event might be associated with a longer return to work. It might also be related to differences in the injuries caused by violence or by trauma or anxiety related to the violent events, that it might be harder to return to work. So these are some of our hypotheses. Okay, so the two research questions I'll focus on today and I will answer today are: first, are certain types of injuries more likely to be associated with violence? And secondly, does violence result in different return to work outcomes? What affects the relationship between violence and return to work for direct healthcare and social workers? So these are the two questions I'll answer today. Okay, just to get us all on the same page, what is the definition of violence at WorkSafeBC defined? So they define violence as the attempted or actual exercise by a person other than a worker of any physical force so as to cause injury to a worker, and includes any threatening statement or behavior which gives a worker reasonable cause to believe that he or she is at risk of injury. So just to give you all all on the same page, this is our definition of workplace violence because of WorkSafeBC, and that's what we assume to be violence. Okay. So where did the study data come from? So as I mentioned before, most of our data comes from WorkSafeBC, and we have included all healthcare and social services occupations. So this includes hospital settings such as acute care or long-term care, and community settings such as community health social services and adult home groups, for example. And we only included workers who had at least 1 day off work. So workers who had an injury, violence related or non-violence related, who did not have 1 day off at least, were not included in our data. And we had data from the years 2010, 2014. So in total, we included over 21,000 injured workers, of which 3,000 workers had injuries due to violence and 18,000 workers had injuries due to any other cause. So it doesn't seem a lot, but it's a ratio of 1 in 6 of violence to non-violence. So 1 in 6 workers had a violence-related event that led to an injury that for which the workers were at least 1 day off work. Okay, and before I go into the results, I just want to say that all inferences, opinions, and conclusions drawn in this presentation are those of the authors and do not reflect the opinions or policies from the data stewards. Okay, moving forward to some results. Just first some descriptives. So the care settings where injuries took place. The blue bars are the claims that were non-violent event, and the red bars were violence events, right? So you have the percentage of injured workers at the y-axis and the different care settings at the x-axis. So you see that for both violence and non-violence acts, so most of the injured workers work in long-term care. This includes both private and public long-term care settings. And then adult acute care. So acute care and long-term care has the majority of the claims, violence and non-violence. But interestingly, if you look at residential social services, there is relatively a higher percentage of violence related claims compared to non-violence related claims. Same in counseling and social services. So this was really interesting because overall there's a 1 in 6 ratio of violence related injuries compared to non-violence related injuries, but in residential social services and counseling there's a much higher ratio of workers with violence events. So these 3 groups, oh, I'm actually pointing at the wrong screen. So these 3 groups in total have less claims, but these counseling and residential social services have higher violence-related claims. Okay, if we look into the occupations, approximately half of the study population are nurses' aides and nurses' assistants. So there's not that much difference between violence-related claims and non-violence-related claims. While there's a higher proportion, yes, there is a higher proportion of non-violence related claims among nursing aides, but this difference is relatively small. And we see the same for nurses. We see that the proportion of injuries due to violence and non-violence are almost similar. Well, if we look at social workers and counseling, like we also already saw in the care settings, but if you look at occupations, social workers and counseling, they are overall the smallest occupation group, but the contribution of non-violence claims contributes almost as much as the violence claims for nurses, you see? So it's really interesting to look into more detail about what's happening for social workers and counselors. And I don't want to de-emphasize nurse and nursing assistant because it's an interesting group to look at, and especially considering the higher proportion of injuries in general. And then if we look at types of injuries, so we classified injuries in 6 different injury types as shown in this graph below. And I want to highlight 2 injuries here. First is the upper extremity sprains and strains. It has the highest proportion, so the red bar, in general, the highest proportion of injuries due to violence. And then I want to emphasize mental health injuries, because mental health injuries are almost exclusively due to violence. So, and I go into much more detail afterwards. And then if you see non-traumatic sprain and strain injuries, you also see a much higher proportion of violence injuries compared to non-violence injuries. And these injuries, you have to think about cuts and contusions and bruises. So yeah, to give you an idea about what non-traumatic, non-sprain injuries are. Okay. So then if we move on to, but how are we actually going to analyze like all these different violence related claims versus non-violence related claims? What is the effect of violence related claims on return to work, on time until a worker returns to work after they've been off for a certain period of time? And in order to have the most accurate picture as possible, we have to make sure that the group of workers who had a violence-related incident and a group of workers who have a non-violence-related incident were as similar as possible on all other variables, so that the only difference between those 2 groups is that they have the violence-related incident or not. So that's why we make sure that age, gender, injury type, the occupation, and the care setting that these workers work in are similar between those workers who have Violence Act and Non-Violence Act. So these are all factors that contribute to time to return to work. So if we make sure these are all equal, then the only difference is if they had a violence-related incident or a non-violence-related incident that led to an injury which led them to take time off work. So we matched these workers, and that led to almost 2,900 workers with a Violence Act and exactly 2,900 workers with a non-violence act. So for those who are interested in methodology, I won't go into too much detail. I again refer to the publication in OEM, but I'll just mention it briefly. And if you have more questions, please contact me afterwards or read the paper, or I can explain anything you want, but for now I'll keep it short. So as I mentioned before, we use matching, or to be specific, coarse and exact matching to prepare the study population, right? So to match workers with violence and non-violence event on all other variables that can influence their time to return to work. After we have created this study population, we use Cox regression models. And Cox regression is a statistical model that allows us to look at the difference in the likelihood to return to work. So we compare the likelihood to return to work between violence and non-violence. However, this is a model that requires the assumption that this likelihood remains constant over time. And we know that the likelihood to return to work is not constant over time. Usually you have a higher likelihood to return to work if you're just injured, and you have a lower likelihood to return to work if you're already off for many months. So when this assumption is not met, we use piecewise hazard models. And this allows us to look at the difference in the likelihood to return to work in specific time frames. Okay, so just a little bit of background. And as I mentioned before, if you have questions about this, please contact me. No problem at all. Okay, so I show you the first result, which is all workers, all injured workers in the study. And here on this is a Kaplan-Meier curve, and on the y-axis you see the percentage of workers who are off work, starting at 100% at the first day after injury, because that's one of our inclusion criteria. And on the x-axis you see the days after the first time loss, going from 0 to 1 year after injury. So what you see is at the end of the curve, so at the end of 365 days after injury, 10.5% of workers injured due to violence were still on claim, and 8.1% of workers injured due to any other cause, not due to violence, were still on claim. So after 1 year, violence-related incidents resulted in a 2.5% lower likelihood to return to work compared to injuries due to any other cause. Okay, two important things to note here. Workers with injuries due to violence return to work, like, it's hard to see, but they return to work almost faster, up until 30 days, like what you see here. The orange line is lower than the gray line, so they return to work faster until like 30 days after injury. But after that time, they are less likely to return to work. So here, after about 70 days, you see this switch, right? So first, workers with violence-related injury, they were returned to work faster, and then about after 70 days, you see this switch, and then they are less likely to return to work. So this indicates, this cross on the Kaplan-Meier curve indicates that the hazard is not constant over time, and that's where we had to use this fractional hazard model. So I showed this fractional measure. This is a graphical representation of the hazard ratios over specific periods over time, in 1 year after injury. So on the y-axis, you see the hazard ratios. And if the hazard ratio is above 1, it means that workers with injuries due to violence are more likely to return to work. And if the hazard ratio is below 1, you see that workers with violence are less likely to return to work compared to workers with an injury due to any other cause. So the dot is the effect estimate, and the lines around it is the certainty or the uncertainty we have around this effect estimate. And you see over time, less workers still return to work. Most workers are already returned to work by the time we reach like half year after injury. So less workers we have, there's more uncertainty about our effect estimate. Okay. So workers with violence-related incident compared to workers with non-violence-related incident had a higher likelihood, like we also saw in the previous slide, to return to work within 30 days post-injury, right? So the hazard ratio is above 1, and also our confidence intervals does not cross 1. So we're pretty sure that workers with a violence-related incident are more likely to return to work within 30 days post-injury compared to workers due to any other cause. But then if we look at the other, until like 7 months, between the 2nd month until the 7th month after injury, they have a lower likelihood to return to work after injury. And then like in the last 2 months, 3 months of the year, we are not sure, like it's crossing the 1. Probably we have not enough workers to give a specific effect estimate about the effect of violence on time to return to work. But going back here to this first month after injury, like why? Why do workers with a violence-related incident are more likely to return to work? So what we think is happening here is that a minor physical non-violence related injury may not lead to time loss compensation, while the same minor violence-related injury may lead to a short period of time loss compensation. So accordingly, a subgroup of workers with minor violence-related injuries would be expected to return to work very quick, while the same group of minor non-violence-related injuries wouldn't experience time loss at all. And because no time loss claims are not comprehensively coded at the occupational and injury level, we were not able to categorize these claims by workers with violence-related incidents and non-violence-related incidents. So no time loss claims are not included in our cohort. So that's what we think that happened. If you're grabbed by the arm and you have a bruise and it's because of a violent act, you might take the next day off to recover from this mentally and physically. Well, if you hit your arm, you have the same bruise, but it's due to a non-violence related reason, you probably won't take time off at all. So that's why we think that we see this. And then after this initial 30-day window post-injury, workers with violence-related incident were less likely to return to work. So that's what we see here, mainly here. So we think that violence-related incidents can lead to a complex combination of physical and psychological injuries. And the data that we were authorized to access didn't provide information on secondary injuries, but we hypothesized that, and supported also by existing literature, that workers with violence-related incident, regardless of the primary nature of the injury, are more likely to have a secondary psychological injury compared to workers with non-violent incidents. So this complexity of diagnosing, treating, and adjudicating psychological injuries for compensation purposes, including for secondary injuries, that may lead to this delay to return to work after this initial 30-day window for workers with violence-related incidents. And this pattern we see among all injuries, except for workers with mental health injuries. So I'm going to dig a little deeper into this. So this is a graph only showing those with mental health injuries by violence-related claims, the orange line, and by non-violence-related claims, the gray line. It's a little more scattered because the population is much smaller. Oops. Okay. So up until 20 days, the return to works look pretty similar. But after that, the curve diverges quite drastically and remains far apart. And by the end of 1 year, 1/8 of these workers injured due to non-violence, so they're injured due to any other cause but violence, stayed off work, right? To 12.5%. But 1 in 3 workers injured due to a violence act stayed off work. So irrespective of whether the cause was violence or non-related, violence-related or non-violence-related, mental health injuries have a more delayed return to work compared to the overall population. But violence has a profound effect on lowering the likelihood to return to work among those with mental health injuries. You see that the lines are not crossing. So the models for mental health injuries did not violate the assumption for proportionality. So for this specific subgroup, I'm not going to show, we don't have to do the piecewise hazard models. So if you look at another group, so for all injuries, but only looking at nurses. So nurses show a very similar Kaplan-Meier survival curve compared to the overall cohort. So violence-related claims have a slightly faster return to work within the first 30 days, about 30 days, and then slower, right? You see in this crossover, and then slower after compared to non-violent claims. However, by the end of 1 year, both violence and non-violence related claims have a higher proportion of people, of workers who return to work compared to the overall cohort. So it means that other occupations have a lower proportion of return to work by the end of the year. Because there was some crossover, we did have to do proportional hazard models, so it shows a very similar trend, this very similar curve as in the overall cohort, in which in the first 30 days, nurses who were injured due to a violence act were more likely to return to work. And then after, like especially here, they were less likely to return to work. But there's a lot of uncertainty surrounding the effect estimate. And then finally, we look at this very interesting group of social workers and counselors. And I think we see a very interesting curve here. So the likelihood to return to work stay the same up until like 30 days, after which we see this divergence where violence-related claims are less likely to return to work. So 15% of social workers and counselors who had a violence-related event that led to an injury is still off work, compared to 6.8% of workers who were injured due to any other cause. Interestingly here, what I find is both curves remained flat. However, after approximately 180 days, we see that social workers and counselors who had injuries due to violence had a higher proportion. So like they all keep returning to work until like after 180 days. After that, basically no one returns to work anymore. The curves stay flat, which is really interesting to look at. And this is reflected in this proportional hazard models. So workers with violence-related incident in counseling or social services occupations were less likely to return to work. So you don't even see that they're more likely to return to work in the first month. So but what we do for sure see is that they're less likely to return to work 1 to 6 months after injury compared to workers in these occupations with a non-violence related incident. So why does this happen? What we thought had happened here is that this difference may be due in part that counseling and social services workplaces may have different organizational policies and practices around violence prevention, and also fewer resources and supports for a return to work. So, for example, all direct care staff in BC's health authorities are required to complete BC provincial violence prevention curriculum training, right? So, and this is not the case for many community social services and outpatient care settings. So accordingly, in these settings, workers may fear recurrences of violence incidents and re-injury because they're returning to a workplace with maybe inadequate violence prevention plans. And on top of that, counseling and social services workplaces are more likely to be smaller and non-unionized and privatized. So all these factors can affect the likelihood of injury due to violence and in their response in supporting and providing accommodated return to work afterwards. So this is something that really triggered me to think about more. Okay, so what are the take-home messages of the results I just showed to you? First of all, workers with mental health injuries are less likely to return to work, regardless of whether this was due to violence or any other cause, right? But if it was due to violence, remember that it was such a profound effect on return to work, where 1 in 3 workers were likely to stay off work by 1 year follow-up periods compared to work due to any other cause. Secondly, the violence is associated with faster return to work in the overall population. Violence is associated with faster return to work before 30 days after injury, but is also associated with a slower return to work for workers who are off work more than 30 days. It's likely due to the severity of injury, but unfortunately, like this study is not set up to tease into the relationship with violence and injury severity, and it's worth considering for future research and for the intervention purposes. So identifying the severity of injury may be key to identifying those workers who will not return to work until after days after injury. And finally, so we saw that nurses and nursing assistants are pretty similar to the overall cohort in terms of results, but social workers and counselors who are injured due to violence are less likely to return to work at 30 to 60 and 60 to 90 days compared to social workers and counselors who are injured due to any other cause. So we know that nurses and nursing assistants are affected by violence, and have good support systems in place at their work environments, such as hospital or long-term care facilities, but social workers and counselors who work in different settings may not have these resources, and we see the effect of violence on their return to work significant. So based on this study, what do we recommend for in practice? So in addition to primary prevention of work-related violence incidents, intervention efforts to reduce work disability once a violence incident has happened, according to this study, should focus on first, healthcare workers with mental health or psychological injuries due to violence. Secondly, workers who are likely to stay off more than 30 days after a violence event, because those workers have a higher likelihood to remain off work the entire year. And increasing resources for workers in counseling and social services. And especially, I think future research would benefit from predictive models of longer disability duration, so that we follow now for more than 1 year, following a work-related violent incidents to help inform intervention strategies. Okay, to make this timely, because we're all in this pandemic and what's happening now in the world, and I found a very interesting article by McKay in The Lancet this year, who was actually describing that attacks and violence against healthcare personnel increased during this world pandemic. And the title of this article is "Attacks Against Healthcare Personnel Must Stop, Especially as the World Fights COVID-19." And I thought this was shocking, because we performed this study with data from a little while ago, and we see that during this pandemic, the attacks against healthcare personnel are rising. Is shocking to me. And they say that effective responses must address the root causes, and that they recommend 6 actions that should be taken immediately. So first of all, they say the collection of data on incidents and type of attacks on healthcare personnel, especially in the context of this COVID-19 pandemic, which I think, like here in Canada, Workers' Compensation Board play a huge role in this, because they have a lot of data. Such attacks against healthcare personnel must be prevented, and when they do occur, condemned. Thirdly, misinformation and disinformation about COVID-19 must be countered. The enforcement of strong actions against perpetrators of attack by local and national governments must be demanded. They say state and local governments should invest the health security measures to protect healthcare workers as part of COVID-19 emergency budgets, which I think is a very important one. And finally, they say health professionals and their associations should unite in speaking out forcefully against all acts of discrimination, intimidation, and violence against healthcare workers. And they say that these actions should be taken now. This article was in the beginning of June, if I remember correctly. They say, by protecting healthcare personnel, we protect our most valuable assets in the fight against COVID-19. Doctors, nurses, emergency medical technicians, medical and respiratory technicians, laboratory workers, and many others in the front line. And I would like to finish this presentation with a quote from Len Rubenstein. He is a chair of the Safeguarding Health in Conflict Coalition. And I know Canada is not in a conflict situation, but this quote for me really resembled the situation that we're in this world pandemic. So he says, the experiences of health workers battling COVID-19 resemble, in an entirely different context, the dangers, shortages, and tough decisions health workers in conflicts face every day. Whether providing care in a war or in a pandemic, health workers deserve protection, support, and solidarity. We must strengthen their protection and impunity and express solidarity with all on the front lines of healthcare, wherever they are. So with that, I would like to end my presentation, and thank you all very, very much for watching this. And please, if you have any questions, I think we have some time for that.
Thank you so much, Esther, for presenting on such an interesting topic and for raising important questions around the return to work of healthcare workers. Also, for making the last part so relevant to what's going on with the COVID-19 pandemic right now. Thank you. Let's move on to the Q&A session, if that's all right with you. So to our audience, if you have any questions, please insert them in the question box. And let's start with our first question. This question is related to the definition of violence by WorkSafeBC. So is violence defined as physical only, and does it refer to physical threats only?
It refers, I think it's interesting to go back to this. So it refers to the threat and the actual attempt of physical force, right? So but it also includes its physical, mainly what we saw, if you look at the injuries, it's mainly physical force, but it also includes threatening statement or behavior. So they keep it pretty broad, which is a blessing and a curse for a study like this, because yeah, we're not exactly, it doesn't give any more information than this. So it includes physical force, but also threatening statements or behavior.
Thank you so much. So to have a better idea of what is considered as violence in the workplace, can you give some concrete examples or some cases that you've run into during your research?
Yeah, I only work with the data, so I know there are other colleagues of mine at the Partnership for Work Health and Safety who do qualitative work. So they actually go out in the field and talk to nurses and do more, like they get the quotes and the information. So I work with the data that we have. So it's difficult for me to exactly say, but if you look at the type of injuries that are caused because of violence, right? So I think this one is really representative of what we see. So these are the injuries that are caused by a violent act. And the majority are like upper extremity sprains and strains. So you can think about, like, imagine someone grabbing you, right? Which causes you strains or sprains in your arm. And we see a really high percentage proportionally of the non-traumatic non-sprains or strains. So these are cuts and bruises. So these are really the injuries most caused by violence incidents or violence. So it's hard for me to say, okay, this is what happened, but if you look at the injuries, the data that we do have, it's mainly upper extremity sprains and strains and non-traumatic non-sprains injuries. So it makes a lot of sense that you have a lot of grabbing and pulling on arms, so that you have sprains and strain injuries, or you have cuts, or you have bruises. But besides that, like the mental health injury, like the trauma the workers can get from, in combination with the physical force. And as I mentioned before, we even think this is an underestimation, because a lot of the mental health injuries are assumed secondary injuries, and we don't have this information about the secondary injuries. So yeah, these are what you can think of that could have happened to a healthcare worker.
Makes sense, thank you. And same question, but for mental health, I'm not sure if you'll be able to answer that as well. So can you generalize what types of mental health conditions were most prevalent in the study population after a violent event?
Yeah, I can't give any exact numbers. Yeah, I'm sorry that it sounds like it's really difficult if you work with a data set that is we have limited information. And luckily there are other colleagues at the Partnership for Work Health and Safety who will have more concrete information, because they actually go out and talk to the nurses or talk to other healthcare workers. I have more general information, so I can't exactly say what are the most common mental health injuries, but it's most likely to be related to the trauma that they have from a violence-related act.
Thank you for trying. Those are tough questions, but thank you, Esther. And our next question is, to the best of your knowledge, why is there such a high rate of violence-related injuries in counselors and social workers?
Yeah, that was a really interesting finding for us. I'm just going to go back to the slides every time. Right, so for me, this was like one of the most interesting findings, and also that there was such a high percentage of violence claims and such a and striking lower likelihood to return to work for this occupation. So what we think that happens is that for nurses, nursing aides in hospital, there are a lot of policies and practices in place for the prevention of violence. And this might not be the case in social worker and for social workers and counselors. They might not have as many violence prevention programs, and they often are smaller settings and non-unionized. And these may factors that first of all might be related to if there are less prevention programs, there might be a higher probability of violence act. And because they are smaller companies, we saw in other research that we did at the partnership that if you work for larger firms, you, for example, also have a higher likelihood of gradual return to work programs, modified return to work programs, and that these kind of programs to increase or stimulate the return to work after any event, they might not be in place in smaller companies. And social workers and counselors, they often work in what we saw, they work in smaller firms. So this all might be related to like smaller firms, non-unionized, and probably less violence prevention programs might be the cause of this, what we see, that there are more violence related claims and a lower likelihood to return to work.
Thank you, Esther. And a related question, could you reflect on the possibility that social workers and counselors are different relationally with clients than the work that nurses and nurses aid perform?
Yeah, for sure. I think totally. Like what I say, we don't know exactly which violence act happens, which I'm actually very interested in, and I'm very curious to see also other work from the partnership who can maybe more dig into the why and like why did these violence acts happen and what exactly happened, because I'm sure that nurses, I'm not sure, I don't have the data on it, but let me say, for me, it's plausible that nurses and nursing aides also have different injuries and different violence act compared to social workers. But on the other hand, as we see so many, let me go back. As we see so many non-traumatic, non-strain injuries, which is probably like the bruises, the grabbing the arm, and also here actual sprains and strains, so which also may be related to like, yeah, spraining your ankle, spraining your wrist. I'm not sure if that's different in counselors and social workers compared to nurses, because it's a lot of grabbing and pushing, which could be the same. But I do think that the relationship with their patients is different. So maybe it does lead to different injury, different violence acts. But if we look at the injuries, I'm not sure.
Makes sense. Thank you so much. Our next question is, in your opinion, what does a successful framework that integrates violence tracking and prevention look like?
Yeah, great question. I would actually like to refer to work done by my supervisor, Professor McLeod, who is working on the leading and lagging indicators to like what is the leading indicator for violence and what are lagging indicators for violence and violence prevention. And he made a good framework on that. I'm sorry, I find it very difficult to answer like what are the best like practices, because I think I'm too far from the field for that. But we do have these recommendations, which is purely based on our data. But these, for me, are the things that I think we should focus on, right? So it's difficult for me to say what should be included in a violence prevention program, because it's not what I studied, so I don't want to give any information that I don't have. But at least I think it should focus on works with mental health injury, but especially what we know in claims data is often underrepresented. So violence prevention intervention program should focus on workers with mental health injuries, workers who are likely to stay off work for more than a month. So you can think about workers with severe injuries, right? If you think that they are unlikely to return to work in the short term, then I think we should focus on giving them more attention, because we see that the likelihood to return to work really decreases the longer workers stay off work. And lastly, like what we talked about quite a lot now, is increasing resources for counseling and social services, because it's such a different field from workers who work in as nurses. So I think we shouldn't forget about them and increase resources for these occupations. And finally, I also think, but that's maybe more for future research, but also interesting for a program, if you think we should also, if we see that still quite a large percentage of workers is still off work, even though it's about 10%, but still these workers are off work for more than a year. And I think it's really valuable to start looking at workers who are really off for the long term, so more than 1 year, to help also inform intervention strategies, like how can we even prevent it, that these workers are off for so long.
Thank you, Esther. Our next question is, how is an injury measured against the hazard ratio? If you know.
How is the injury measured against the hazard ratio?
Yes. How do we consider an injury above 1 or below 1, for example?
Okay. So I go back to I think I understand the question, and I didn't show the results stratified by injury, because this pattern is consistent among all injuries. So except mental health injuries, which I show in the next slide, remember? So this is a similar pattern for workers with all injuries. So we see that within the first month, the hazard ratio is above 1, which means that workers, regardless of which injury is followed by the event, we see that workers with a violence-related event are more likely to return to work in the next 30 days. And because of the matching that we did, we make sure that for every worker with a violence event, for example, a worker with a violence event who has back sprain, we also make sure that there's a worker with a non-violence event who has a back sprain. So we compare the workers with non-violence events and workers with violence events within the same, who have the same injury and the same age and the same gender and work in the same occupation, so that everything is equal except for the fact if they had a violence-related act or not. But then if we also did it separately for all injuries, and then we see a very similar pattern, except for mental health injuries, what I showed here. For mental health injuries, we see a slightly different pattern. What you see is that workers with a violence-related act are all throughout the year less likely to return to work than workers with a non-violence act, so an injury due to any other cause. And because this assumption of proportionality, so you don't see a crossover of the two lines at any point, we don't have to do this proportional hazard model. We can interpret the result based on this Kaplan-Meier curve, showing that all over the year, throughout the year, workers who have an injury, a mental health injury due to violence, are less likely to return to work compared to workers who have a mental health injury due to any other cause. For all other injuries, we see this pattern, or if it's easier, this pattern, where we see this crossover. In the first month, workers with violence-related, who had experienced violence and then had any injury, a back sprain, a traumatic sprain, no, name it, any injury, they are more likely to return to work and less likely to return to work in the rest of the year. Does that answer the question? If not, if you have another question, please, contact me after.
Sounds good. We will collect any extra questions and send them your way. So another question, talking about the differences between violent and non-violent related injuries. So you said that there is a difference in time compensation. Would you be able to elaborate on that? And do you know why is there a difference in time compensation between violent and non-violent related injuries?
Yeah, so So that's exactly this slide. So yeah, the reasons that we try to give is why we think that workers who experience violence return to work quicker in the first month is probably not because they return quicker, but because they have workers with a violence who experience violence and who have a minor physical injury probably take a few days off to recover not only from the physical injury, but also from experiencing violence. While workers who had a minor physical injury due to any other cause probably didn't take any time off. So that's probably why we see that they return a little quicker, because workers with the same minor physical activity who is, for example, caused by a fall or they hit themselves or anything, they don't take any time off. That's our hypothesis. So further, in the second, like why workers who experience violence are less likely to return to work, especially like between 30 and 270 days after injury. It's probably because we saw that, or what we hypothesize, is this complex combination of physical and mental health injuries that is caused by violence, by experiencing violence. So, as I mentioned before, we don't have any information on secondary injuries, which is a shame because secondary injuries are likely to be also mental health injuries. But we hypothesize, and it's supported by existing literature, that workers who experience violence, and regardless of the primary nature of the injury, are more likely to have secondary psychological injuries compared to workers with non-violence incidents. And this complexity of having experienced violence and maybe trauma, as well as having a physical injury, and it's very complex in diagnosing and treating, and also in adjudicating psychological injuries for compensation purposes, right? So including secondary injuries. So this whole complex combination of injuries after a violent act, we think that might delay your return to work process. And that's probably why we see this delay in returning to work here.
Perfect, makes sense. Thank you very much. Another question is, have you looked into if there is a correlation between wage level with and the return to work outcome?
Yes, we have. I tried to remember that. Is this one of the variables that we matched on? No. So usually what we do is we match on variables that have an impact on return to work. And if wage category, well, we controlled for it, so we made sure that the wage levels were similar between all workers, because we didn't want it to have an impact on return to work, but we didn't match on it, and probably because it didn't have a big impact on the relationship between if you had a violence effect or not and your likelihood to return to work. So that's my answer for now. I know we look at it in a lot of studies. We always include it as a confounder, so we control for it so that it doesn't have an impact. But it also means that I don't know now exactly what the difference is, because usually we make sure that the income levels are controlled for. They are similar between workers with violence and non-violence act. It's in an appendix in our paper. So if you're really interested in it, I would recommend you to look at it here in our paper, because I know it's in our, we haven't looked at the stratified differences. So for each, for example, income group, what are the differences in likelihood to return to work? In my memory, there were not really big differences. Otherwise, we would have matched for it. So that's my answer for now.
Perfect. And as we mentioned, we will have those resources for our audience later on our website. Our last question is, what are the future steps in terms of your research on this subject?
Yeah, I would definitely keep an eye on the partnership website, because there is more research on the impact on violence in the healthcare setting done at the partnership by colleagues of mine. It's not my primary field of research. It's one of my students who did this study. So please take a look at the partnership website. What I think is very important for future research in this field is also to include longer term outcomes. We tend to look at what is the impact of violence within 1 year, but there are so many workers, what we saw now, about 10% of workers who don't return to work within this year, and we don't know enough about them. So for me, that's really important. And secondly, of course, in like what the Lancet, this article in the Lancet also announces, like the impact of violence in this world pandemic, it's an increasing attacks to healthcare personnel in COVID-19 hospitals. It's, for me, it's something I can't imagine. I really think we need to study this, but more important, prevent this.
Perfect. Thank you so much, Esther, for demonstrating the importance of focusing on healthcare workers with psychological injuries and on workers who are off for more than a month after a violent incident, in addition to the primary preventions of work-related violent incidents and the interventions to reduce work disability related to violence. We really appreciate your time and your work. Thank you.
Thank you so much for the invitation.
And to our audience, thank you for your participation and continued support. The recording of this webinar will be available on our website along with the slides. All registrants will receive a notification email when these items are available. A reminder that this program is valid for 1 PDC or professional development credit for the SHRM-CP or SHRM-SCP recognized by the Society for Human Resource Management. If you're a WWI member or VRA Canada member, you receive free certificates of attendance. Otherwise, there's a $15 administration fee. Immediately following this session, you'll be directed to the evaluation survey. We greatly appreciate your input on our webinars as well as suggestions for future topic areas. Please visit our website for more details at workwellnessinstitute.org. All of our webinars are accessible to the public. Thank you again for your participation. Thank you, Esther. Stay safe and take care of yourselves.
Thank you.